A very warm welcome, and I'm delighted to be with you today at the Belfast Profiling Health, Wellbeing and Prosperity Has COVID-19 Changed Our City seminar. I'm going to be chairing the event this morning. I'm also the Vice Chair of Belfast Healthy Cities and a member of the Profile Steering Group, very small steering group. And in a past life, I was Course Director for the MSc in Public Health at Ulster University. As this is a webinar, if the participants, they will be mute with their cameras off, please. That's standard. But we would encourage you to please add questions to the Q&A box at the bottom of your screen. The presentation from speakers will be recorded and it will be uploaded onto the Belfast Healthy Cities website, as will the documents for each of the 6P chapters. If you're using Twitter, you may wish to include the hashtag #HealthyBelfast, or include @BelfastHealthy in tweets displayed on the screen. So this webinar is going to launch the 6 follow-up chapters to the 2022 Belfast Profiling Health, Wellbeing and Prosperity, the data behind the people and the city. So we're calling that the original documents. So based on the availability of data, key indicators were selected from those initial chapters to outline the changes that occurred during the COVID-19 pandemic across the city. And we're absolutely delighted this morning to be joined by Professor Sir Michael McBride, Chief Medical Officer from the Department of Health, which many of you will know, to launch the chapters. Also by Erica Eisen, Specialist Practitioner in Population and Public Health, who authored the chapters, the COVID chapters, as well as the initial chapters. Dr. Graham Alabaster, Head of Geneva Office, United Nations Human Settlements Programme, and Maud Leurn, Coordinator of the French National Health Cities Network. And Graham and Maud will be joining us by Zoom, and we have Professor Sir Michael McBride here with us. So as I say, we're absolutely delighted that Professor Sir Michael McBride can join us today to give us the opening address. Dr. McBride was appointed to the post of Chief Medical Officer, he's frowning at me, for the Department of Health in September 2006. Prior to joining the department, he had been Medical Director at the Royal Group of Hospitals from August 2002. And as Medical Director at the Royal Hospitals, he contributed to strategic change at trust, regional and national level. As the Trust Lead for Clinical and Social Care Governance, he had responsibilities for all aspects of clinical quality and patient safety. Dr. McBride took up the post of CMO during a time of significant change for health and social care in Northern Ireland, with responsibilities for policy and screening in relation to public health, quality and safety and research and development. He also provides strategic advice to ministers and other government departments on health-related matters. He has been closely involved in the development of the new health and social care structures post-review of public administration, including the establishment of the Public Health Agency, and also in developing a range of service frameworks across Northern Ireland. Dr. McBride currently leads in the work to transform health and social services in Northern Ireland in line with the Health and Wellbeing 2026 Delivering Together document. So I'm now going to hand over to Professor Sir Michael.
Well, good morning everyone, and thank you, Karen, for those very kind words of introduction, even though they were a little lengthy and a little dull for me. But it's great to be here, and it's great to be invited along this morning to help launch the updated chapters to Belfast City Health Profile, which has been updated to reflect the impact of the COVID-19 pandemic. Involvement with Healthy Cities movement has made a unique and valued contribution to the delivery of UK and Northern Ireland public health agenda to date. And indeed, Belfast was one of the first cities designated to the World Health Organization European network back in 1988. Belfast was, of course, a very different city then, a time when conflict pervaded all aspects of society. So it was very positive and indeed courageous move for the city to reach out to people, to bring people together and to promote collaboration with the aim of improving health and well-being for everyone in a once troubled city. Belfast's commitment to the European Healthy Cities Network provided a structure and a framework of priorities for public health, and it helped galvanise local politicians around the concepts of the social determinants of health and inequalities in health. It also helped to reinforce the fact that health is a responsibility of all sectors, and this is key to addressing those social determinants. Over the 7 phases of the European network, Belfast Healthy Cities has worked consistently to place health and well-being and health equity on the policy agenda of all sectors in the city. Joan and her team are to be commended for their tireless work in this regard. They have brought together government departments and agencies, the public and community and voluntary sectors to improve policy formulation within the city, to build and contribute to strategic partnerships for health development. And this type of collaboration is vital as we move forward post-pandemic. The benefit of the city's involvement through Belfast Healthy Cities has also reached out to influence beyond the city boundaries by helping to inform wider regional policy and action through working with other sectors and departments in the areas of health, inequalities and well-being. It has introduced new concepts to the city, such as city health development planning, healthy urban design and age-friendly cities, and has provided a testbed for best practice and evidence on how the health of a city can be improved. Making life better is the Northern Ireland Executive's overarching strategic framework for public health. It commits us to creating the conditions for individuals, families and communities to take greater control over their lives and to be enabled and supported to lead healthier lives. The work of Belfast Healthy Cities is closely aligned to these ambitions, and I am proud of our close association and working relationship. Making Life Better provides direction to guide the development and implementation of collaborative action in government at both regional and local levels. The framework has been developed on an evidence-based theory of change, recognising that health and well-being and health inequalities are not just the outcome of the clinical services that we provide, but are primarily shaped by many important factors, including age, family, community, workplace, beliefs and traditions, economics and physical and social environments. A mid-term review of the Making Life Better policy had started in 2019. However, this process and this review and other strategic work on the framework had to be paused due to the impact of the pandemic and the need to prioritise the response to COVID-19, both within the Department of Health and across the wider system. However, work to implement the framework, delivering on its underpinning public health strategies, to address inequalities on the ground continued during this period, and indeed the pandemic itself emphasised those health inequalities, as all pandemics do. Recovering the health of the population is one of the department's key priorities following the COVID-19 pandemic. It was therefore agreed that rather than continue with the review, a number of practical initiatives would be progressed on a cross-departmental and agency basis. And these projects will add real value to our local communities at this extremely challenging time and will help address the health inequalities which were exacerbated by the pandemic. The initiatives are aligned with the policy responsibility of other executive departments, and that we hope will enhance cross-departmental working and benefit from the collaborative gain in a cost-effective way, making best use of all our resources. Another key priority within Making Life Better is improving health literacy. There has been significant and growing interest in this area, both internationally and locally, as a mechanism to support improving health and well-being and to reduce health inequalities. Indeed, the World Health Organization Roadmap for Health Literacy advocates a whole-of-society approach, embedding health literacy at policy, organisation, community and individual level. Several factors make it a compelling and timely topic. Literacy and health literacy are fundamental components of pursuing health and well-being in modern society. As people are increasingly exposed to complex information and complex systems, including healthcare systems, becoming a health literate person has become a growing challenge. Yet at the same time, people have ready access to more information than ever before through various online sources and devices. And importantly, we understand that poor health literacy adversely affects people's health. Literacy has been shown to be one of the strongest predictors of health status, along with age, income, employment status, education level, and race or ethnic group. Improving health literacy is therefore an important component of improving overall health. That is why health literacy is a key dimension of Agenda 2030, the European Health Policy Framework, and making improvements in this area is particularly important as we continue to emerge from the pandemic and face the legacy issues of COVID-19. We have worked closely with Belfast Healthy Cities on health literacy in the past and look forward to continued collaboration in the future. There is no doubt that COVID-19 had a substantial impact on our nation's health. It has affected the population's physical and mental health and hampered access to care. The impact has not been equal across society, with some groups being more deeply affected than others, especially those who already had worse outcomes before COVID-19. Infection and mortality rates have been much higher, for example, among older people, people from certain ethnic backgrounds, and disabled people. This has in large part been due to pre-existing health inequalities, those health inequalities that, despite our efforts, we have not fully addressed. Beyond its immediate impact on the physical and mental health of the population, the pandemic has also affected many wider determinants of health, including education and employment. The health and development of children was affected by school closures, and these disruptions to education will likely have significant consequences for children and young people's health, both now and into the future. COVID-19 also affected employment and financial security for many people. Again, this has not been equal, with some groups such as women, young people and certain ethnic minority groups disproportionately affected. Reducing inequalities in health is a huge challenge for us all. It needs sustained collaboration across government, the community, the voluntary sector, and with communities themselves, now so more than ever before. This is particularly pertinent in Belfast, which is some of Northern Ireland's most deprived areas and has poorer health outcomes than the Northern Ireland average for the majority of health indicators. These health inequalities are highlighted further in the chapters being launched today to update Belfast's city health profile by reflecting on the ways in which COVID-19 has changed our city. Thank you. I'll now pass you back to Karen, and I trust that you find today's event both useful and informative. Thank you very much indeed.
Thank you, Dr. McBride. I'm now delighted to welcome Erica Eisen back. Erica is an honorary member of the Faculty of Public Health and a specialist practitioner in population and public health. And Erica is going to give us a summary analysis of the 6 chapters. Erica is a specialist practitioner in health impact assessment, health in all policies and health equity. She has worked as an expert advisor in health impact assessment and health in all policies for the World Health Organization headquarters in Geneva and in the WHO regional office in Europe and the Western Pacific and in the European Network of Healthy Cities. She was involved in a large European Union project training civil servants from health and other ministries in health inequalities impact assessment, and has worked on forms of impact assessment with individual ministries of health in countries such as Belgium and Brunei. For the last 20 years, Erica has worked regularly in Belfast with Belfast Healthy Cities, and through Belfast Healthy Cities with a variety of public and community sector organisations and communities. Latterly, this has involved the research, analysis and interpretation of indicators in the City Health Profile for Belfast, both before and during the COVID-19 pandemic. For Public Health England, now the Office for Health Improvement and Disparities, Erica worked on the Global Burden of Disease programme for England, with a focus on the population's health burden in relation to deprivation, and on several projects relating to impacts on health and health inequalities. So welcome back, Erica.
Thank you for that welcome, Karen, but also Joan as the head of Belfast Healthy Cities. It's always a great pleasure to come to Belfast and to work with you all, and it's truly been an honour over the last 20 years. So thank you for those opportunities. So today, as Karen indicated, I'm going to be talking to you about how COVID-19 has changed some of the indicators we looked at in the original profile. I first want to look at, though, why population profiles are important and how we can use them. So, indicators in population and public health, they are summary measures that we use to help us understand an issue. So indicators can be used to monitor health and the wider determinants of health, but they also enable us to make comparisons over time, comparisons between different geographical areas, and comparisons between groups of people. So they can help us identify factors that affect health and well-being. They can help us identify the needs of a population and how great those needs are. They help us, as people have already indicated, identify health and other inequalities, which is especially important in a city such as Belfast, whereas Professor Sir Michael McBride has indicated has some of the highest areas of deprivation. Importantly, though, indicators give us insights to help with the planning and design of services, and indicators can help to support decision-making when used in conjunction with other types of information, such as the published evidence, but also consulting with communities or service users. Okay, what can the data show us? I think it's important to put this up front, because we mustn't expect too much of data and we must use it within its limits. So there are two main types of data, quantitative data and qualitative data. What can they both show us? So quantitative data, which is the majority of the data in the population profiles, including quantitative data from surveys, and Northern Ireland is very lucky in having a lot of organisations that do surveys regularly. It can show us if there is a problem, how large or widespread that problem is, does that problem change over time, and is that change favourable or unfavourable? Does the problem affect some groups rather than others? Are some areas affected more than others? And importantly for me, looking at quantitative data helps prompt us to ask more important questions that can be answered using qualitative data as well. So why is qualitative data important? Because it can tell us why there is a problem. It can help us understand that problem more, and it can also inform what we can do about it. So a combination of these two types of data, especially when we're looking at smaller geographical areas, can give us an increased understanding of the issue, and it can give us a foundation for a universal service, such as we have in the United Kingdom, to look at the scale and intensity of service provision we need to deliver to our communities in order to address their needs. Sorry, this is not very good. Okay, this is the proviso, data availability during COVID. Unfortunately, when we were doing the profile for COVID, needless to say, the data we had available to us to do the first profile was not available to do the impact of COVID. This was for lots of very good reasons, including the fact that data collection methods had to change because of the restrictions during COVID, and some data couldn't be collected at all because of the nature of the data collection. If a survey was conducted, the sample sizes were reduced, and therefore we have to be more cautious when we're interpreting the data. And changes were also made to the calculation and presentation of some of the indicators. And then finally, some of the services we were looking at, for instance, screening services, there was actually a pause during lockdown for those services. So we don't have full data sets for some of the years this is being undertaken. So a lot of data holders have recommended caution when we look at the data and say, okay, what's been the change pre-COVID and during COVID? So when we look at this profile, we have to bear that in mind. But as these are the only data we have, and these are the basis for our planning, then we have to accept those. We have indicated in the profile where any data holder has put a proviso against the data we've been using. So, as you know, there are 6 themes, and I'll just go through each theme briefly about the changes that happened for the indicators for which we were able to get data. So, looking at people first. Oops, sorry, this is not a very good clicker. Something terrible has happened with my slides. These yellow marks do not coincide with what I wanted, and also not all the slide is showing. I don't know whether you can do anything about it. Let me just click back to the...
Probably not at the minute.
Okay, this is also not a very good clicker. I can't seem to... Yeah, thank you. Okay, so first off, just to look at deaths from COVID in 2020 and 2021. So there's data for both Belfast LGD and Belfast Health and Social Care Trust. So what happened in 2020 for both of those jurisdictions, compared with Northern Ireland, the standardised death rates due to COVID were higher in both Belfast LGD, Belfast HSCT, and then also for deprived areas in both of those jurisdictions. However, between 2020 and 2021, the standardised death rate for COVID-19 increased in Northern Ireland, but actually decreased in Belfast LGD and Belfast Health and Social Care Trust, and in the deprived areas of both of those jurisdictions. So by 2021, we find that Belfast LGD actually had the same standardised death rate as that in Northern Ireland, and Belfast Health and Social Care Trust actually had a lower standardised death rate. So although the death rate is a tragedy, having had a higher death rate in Belfast, whichever jurisdiction you look at, compared with Northern Ireland, this got better. Okay, this is actually now quite difficult for people to read. So can I just explain what I've tried to do with these tables? The machine has discombobulated them. But for each of the 6 chapters, what I've given you, and you can look at the slides when they're on the website, I've given you all the indicators we were able to look at, and then I've looked at what has happened over time. And if I can just use to point, these yellow marks are meant to be over the ones I want to highlight, which they're not at the moment. So I'm going to skip these table slides completely, which will be improved when you can see them on the website, and just go to these slides, which are summary slides of the tables. So in this slide, I'm showing you the impact of COVID-19 on the indicators we were meant to look at in the table. So I don't know if you can see my little presenter thing is in the way, but actually what I've done is shown you the indicators where there was an increase. Thank you. So actually there was an increase not only in the level of anxiety through surveys, whether we looked at the average anxiety score or whether very low levels of anxiety decreased. There was an increase in the prescription rate for mood and anxiety, an increase in alcohol consumption, and also an increase in smoking habit, whether that was tobacco cigarettes or e-cigarettes. So I think this is probably to be expected that people were undertaking these behaviours in response to the stress of the pandemic and lockdowns. At the same time, we also saw a decrease in life satisfaction, in people's feelings about whether what they did in life was worthwhile. In terms of maternal health, breastfeeding on discharge went down, and it went down quite considerably in deprived areas of Belfast. The dental registration rate in children and young people under the age of 18 also went down, and that was pretty much across Belfast. When we look at the more fine-grained data later on, you'll see that 6 of the 10 district electoral areas, the dental registration rate went down for under 18s. Cervical screening coverage also decreased, and so did breast screening uptake. So we have an increase in anxiety, and that was shown in behaviours such as alcohol consumption and smoking, and we also had feelings of a decreased life satisfaction, feeling worthwhile, and then more medical issues. So I'm going to look at prosperity now, and prosperity covered both the labour market and education. So again, you've got the table. The yellow highlight is meant to show what I'm interested in, but discombobulation. So we'll go to the summary slide. So if we look at employment and income, first of all, what we can see is that in terms of the employment rate, that decreased. Gross disposable household income also decreased, and consequently the number of working age people on universal credit increased. However, it should be said that that increase happened in conjunction with the actual rollout of universal credit. So it's not possible to tell how much of that increase is due to the pandemic and how much would have happened anyway as people transition from job seekers allowance and other benefits. However, food poverty did increase, and in Belfast Health and Social Care Trust, prior to the pandemic, food poverty in the Health and Social Care Trust in Belfast was at its lowest, and now Belfast Health and Social Care Trust has the highest food poverty of the 5 health and social care trusts. And also the number of primary pupils with free school meal entitlement also went up. So in terms of employment and income, we can see that the employment rate has gone down, household income has gone down, the number of people on working age people on universal credit has gone up, food poverty has gone up, and the number of primary pupils entitled to free school meals has gone up. The one thing that I can't explain, thank you, is economic inactivity decreased. And this is what I mean about what you can tell from the data and what you can't tell from the data. We would have expected economic inactivity to increase rather than decrease. And what I've given you here, I won't go through it, but if you look at a lot of economic models, this one is from the Bank of England. They have the most tremendous resource that I've only just discovered, so I'll be an evangelist about it, called Bank Over Ground, which gives you lots of details about the economy. And this is a paper, I've taken this figure from a paper they've written called How Does COVID-19 Affect Economic Activity and Inflation? So the Bank of England thought economic inactivity would go up, and I've given you the diagram. Other really exciting things that I found, if you are interested in this, I particularly want to highlight the middle resource, which is the impact of COVID-19 on Northern Ireland's business activity, done by maybe colleagues of Karen's at the University of Ulster. What's interesting about this is they looked at the sectors in Belfast, the employment sectors in Belfast, to work out how resilient they were or how susceptible they were to economic shocks. But all of these resources I've given you all point out how we would expect economic inactivity to increase. So I'm not quite sure why it's decreased overall in Belfast. So that's one of the reasons why you need not just quantitative data, but other forms of data to help you work out what's going on. Okay, so looking at education, this is a bit of a mixed picture, but the things I want to highlight is that the number of pupils who had special educational needs, stage 5, increased. Also increasing, but not to the levels of other local government districts. GCSE attainment, including English and Maths, 5 grades A to C, GCSEs with English and Math, that did actually increase for both free school meal entitlement pupils and non-free school meal entitlement pupils. However, the increase wasn't very large compared to other LGDs. There were more school leavers entering employment and training from Belfast, but there were less school leavers entering higher education and further education. So the good news was there were less school leavers entering unemployment or going to unknown, and I think what happened was previously the ones that would have been unemployed went into employment and training, but there was a decrease in pupils going into higher education and further education. The picture is a lot clearer when we get to district electoral area level, and that data's a bit later on. One thing I do want to emphasise here is about the importance, as Professor Sir Michael McBride has pointed out already, of education. I don't know about you, but I'm 67 and I'm pretty fed up of people telling me as an older person I must exercise a lot in order to stop myself getting dementia. Okay, there's the Lancet Commission on Dementia Prevention, Intervention and Care, and they've updated the evidence base. They found, now we're only talking about the factors we know that we can modify at the moment on the evidence base for preventing dementia. Now, at 8% is hearing loss in midlife. Okay, I'll go with that. But the thing that really shocked me and upset me, but I want, you know, it really underlines how important education is. At 7%, less education in early life. That we can actually do that for our children and young people. We can give them better quality education, and we will be reducing dementia in older age. And I would like to point out that physical inactivity in later life only gets me 2%. So, if I'm going to put money anywhere, it would be education in early life if I'm talking about dementia prevention, as well as obviously hearing aids and hearing tests for people in midlife. So, sorry, soapbox moment over, but I think that's important. So, now, moving on to the planet, this is where Belfast shines in some aspects. So, sorry, we've skipped 2. Yeah. So, first of all, I'll talk about the carbon emissions. This is where Belfast actually does really well. Belfast does pretty well anyway, pre-pandemic, but during the pandemic, carbon emissions for most of the things we looked at, total carbon emissions, whether total for Belfast or within the influence of local authorities, they decreased. Transport carbon emissions went down in Belfast, domestic carbon emissions, and also, very importantly, although for total carbon emissions, Belfast is one of the highest, that's because it's a large urban metropolis. However, if we look at total carbon emissions per capita, Belfast has the lowest. which I think is important of any local government district. So you're doing well on carbon emissions, and as we would expect, not just with the carbon emissions going down, electricity consumption went down as well during COVID. However, not so good. Sorry, this clicker is not my friend. Can I have the one with arrows? Yeah, great, thank you. So, carbon emissions, Belfast doing really well, and it has the best total carbon emissions per capita that there is, so brilliant. Where you're not doing so well, during the pandemic, the amount of household waste per capita went up. Maybe wouldn't have been so bad, but actually the amount of household waste that went into landfill increased, and the amount of household waste that went to recycling decreased. So that wasn't too good. And actually the number of noise complaints increased. That could have been as well during lockdown. People are more confined to the domestic situation, and there may have been more stress. People might have complained more about the noises they were exposed to. So the only thing as well that I'd like to add about the carbon emissions is domestic carbon emissions are maybe an area that Belfast could look at rather than transport. Domestic emissions are a larger proportion of the footprint. Looking at air quality in Belfast, during the pandemic, again, air quality improved as we would expect because there were less cars driving around, etc. So I've just given you the data for Belfast sites as part of the national UK automatic urban and rural network, where Belfast has sites for monitoring nitrogen dioxide and particulate matter 2.5, that's the finest matter, particulate matter that we measure. And I've also given you local air quality management data. So the only thing that was a negative, there were sometimes exceedances of the daily mean objective for PM10, which are the larger particles that we inspire from the air at both Belfast Centre and Stockman's Lane. But in general, air quality did actually improve during the pandemic. However, as you're a WHO healthy city, I do just want to highlight that in 2021, WHO updated its guidance on air quality levels for 6 pollutants where the evidence has become stronger or new evidence has developed. Now, of particular note, especially for Belfast, the evidence of the effects of particulate matter, both PM10, the larger size particles, and PM2.5, it's shown that both of those particulate matter types can penetrate deep into the lungs. They can and PM2.5 can enter the bloodstream, primarily affecting the heart and the lungs, but it can also affect other systems. Now, if we take those new guidelines and we look at Belfast data, what we find is there would have been failures in PM10 at Belfast Stockman's Lane, PM2.5 at Belfast Centre, and there would have been breaches of nitrogen dioxide at 6 places in Belfast: Belfast Centre, Ormer Road, Newtonards Road, Belfast Westlink, Roden Street and Belfast Stockman's Lane. So although air quality improved according to the new WHO guidelines, there still would be work to do for both PM, particulate matter and nitrogen dioxide. So moving on to place, this falls into 2 parts really. The number of people seriously injured in road traffic collisions actually went up during the pandemic. I'm not sure why that might be. Maybe it was due to changes in driver behaviour with not driving and then being allowed to drive again. Pedestrians or cyclists, having got used to not many cars around, then were not aware. Anyway, it's quite noticeable. There was an increase in both fatalities, although those are pretty low numbers, but the number of seriously injured did increase. However, the situation with walking, people were more likely to walk any journey up to 2 miles or 3 kilometres, and also there was an increase in the satisfaction with the current situation for walking and walkers in the local area. Again, sorry for the messy slide. This is really one of the most important ones for me, looking at housing. I'm so sorry about this discombobulation. So we'll go to the summary slide. So this is looking in particular at the housing situation in Belfast. So the key facts are the need for social housing increased during the pandemic, but the total allocations of households to the social housing sector decreased. So we've got an increasing need, but a decreasing supply in the social rented sector. The percentage of households on the waiting list who were actually allocated social housing decreased. So again, that's a negative. Although the number of new dwelling completions for social housing increased, there were almost 3 times less completions in the social rented sector than in the private rented sector. So we've actually got increasing need and decreasing supply, basically, for housing. If we turn to the private rented sector, average rent per month increased in the private sector by £72 a month on average, which is almost £1,000 a year. And also we had a decrease in the total number of working age people, stroke households, receiving a housing related benefit. Now, I don't have time to go into that, but because of the transition from housing benefit to the housing cost element of universal credit, it's not quite clear because I'm not comparing the same data, but actually I calculated that there were around 4,000 less households stroke working age people not receiving a housing related benefit if we compare it pre-COVID and during COVID, and at a time of health and economic shock. That is a bit worrying, but we'd need to do more work to find out what was going on there. Oops. If we go to participation, unfortunately, due to data availability, all we have on participation is to do with caring. So this is the summary slide for caring. So the percentage of people with a caring responsibility increased during COVID. That's not surprising because of the number of people affected by COVID. Obviously, because of lockdown, the number of people who were offered carers assessments by Belfast Health and Social Care Trust decreased because the assessments couldn't be done in people's homes. However, the number of assessments that were accepted actually increased, as did the percentage of carers assessments that were offered that were accepted completed. So people with caring responsibility increased. The number of carers assessments completed increased, and the percentage of carers assessments that were offered that were accepted completed also increased. However, the number of carers assessments did have to decline during the pandemic, and also there was a decrease in claimants of carers allowance. Now, carers allowance is actually quite stringent. You have to give over 35 hours of care a week in order to be able to claim it. So it's not surprising that the number of claimants of carers allowance might have decreased, even though the number of people actually caring increased. Moving on to the peace section, again, due to the availability of data, it's mainly crime that we're looking at. So just to move on to the summary slide, in terms of crime, it's normally reported, the ones we've looked at, domestic abuse and 3 hate crimes, it's normally reported first as an incident, Then the police decide whether it should be a recorded crime or not, and then we have the sanction outcome rate for the recorded crimes. So what happened with domestic abuse is that the number of incidents remained the same. We think this might be because victims were maybe not able to report an incident because of lockdown, confined to the home. But however, the recorded crimes for domestic abuse, that's the police deciding whether an incident is a crime or not, did actually increase. In terms of hate crime with a racist motivation, with a homophobic motivation, and with a sectarian motivation, the number of incidents increased and the recorded crimes increased. So there was overall quite an increase in hate crimes during the pandemic. It's important to note, however, that police recorded crime went down overall, but the other indicator we looked at on crime, if you saw the previous profile, was the experience of crime. Unfortunately, we only have Northern Ireland data for that. Due to the pandemic, Northern Ireland wasn't able to run the experience of crime survey during the pandemic. So there's only, well, they ran the survey, but the sample size was too small to actually pass it out at local government district level. So we don't have any experience of crime data other than for Northern Ireland, but police recorded crime went down in Belfast. But we have this increase in domestic abuse crimes and incidents and crimes for the 3 hate crimes we looked at. In terms of child protection, I think what I'd like to point out is the number of children and young people on the Child Protection Register actually increased in Belfast Health and Social Care Trust. But it's quite interesting when you look at the data, which age groups are on the register. So at 31st of March 2020, the greatest number of children on the Child Protection Register were aged 1 to 4, and then the next largest group were children aged 5 to 11. Now, the worrying thing, I think, in terms of what might have happened during the pandemic that the data can't show us, is that children from the 5 age groups, which is less than 1, 1 to 4, 5 to 11, 12 to 15, and then 16 and older, all of those age groups increased on the Child Protection Register, apart from children under 1. Now, that could have been because that wasn't detected. It doesn't necessarily mean that there might not have been child protection issues for that group of children. Again, it's something we can't know. And the 2 age groups that had the largest percentage increase, but that was from a low baseline though, was children 12 to 15 years and children over 16 years. So although the largest numbers are in the 1 to 4 and the 5 to 11 age group, there was quite a large increase for young people 12 to 15 and over 16. Okay, sorry, I've just said all that. Okay, this is the data by assembly area. Now, I didn't put any yellow on these, so they're not as badly discombobulated. So if we look at the 4 assembly areas, Belfast East, Belfast North, Belfast South and Belfast West, what we find are, for most of the indicators, the 3 health and well-being ones we have at this level, the data at this level, life satisfaction, feeling worthwhile, and level of anxiety, we can see that both Belfast North and Belfast West have either the lowest life satisfaction and feeling worthwhile, or relatively high, or the highest levels of anxiety. If we then look at sort of employment income, again, we're looking at Belfast North and Belfast West. If we look at the sort of special educational needs, both stages 1 to 4 and stage 5, then again, we're looking at Belfast North and Belfast West. Free school meal entitlement, same thing. However, when we get to GCSE attainment for free school meal pupils, although Belfast West was the highest, then Belfast South had relatively low levels. And if we look at GCSE attainment for non-free school meal entitlement pupils, then we go back to our pattern of Belfast North and Belfast West. If we look at caring, what we see is part of what we saw before the pandemic, that Belfast North and Belfast West, they had high numbers of long-term sick people and high numbers of carers in those assembly areas. And this is reflected both in terms of the number of people who claim carers allowance and the number of people who perceive it. But I did also want to highlight that Belfast East, although they don't have such high numbers of carers and recipients, if you look at the percentage of carers to recipients, then they have the lowest, which means there are people in Belfast East who believe they should receive this allowance who are not. If we look at the impact of crime, it's a bit more varied. Essentially what comes out is that Belfast North and Belfast South have the biggest problems. But what's interesting is when we look at the sanction outcome rates, then I think they're varied among the assembly areas and they need attending to. If we look at that overall, what we can see is that Belfast North and Belfast West have poor outcomes in terms of health and well-being, the labour market, education and benefit-related indicators, and Belfast North and Belfast South have poor outcomes for crime. If we look at district electoral areas, the pattern that becomes clear over the indicators that we have looked at, so we have quite a few health indicators here. We've got the COVID-19 death rate, emergency admissions, dental registration, smoking in pregnancy, breastfeeding on discharge and prescription rate. We can see that the pattern is Court is one of the most, is one of the district electoral areas that has some of the worst outcomes, together with Old Park and Black Mountain, and Titanic has a few. And then if we look, I think particularly at GCSE attainment for both types of pupil, both free school meal entitlement pupils and non-free school meal entitlement pupils, then Court and Titanic seem to have some of the worst outcomes. So we have Court, Black Mountain, Old Park, down the northwest side of the city, and then Titanic in the east near the end of the lock. And those are the district electoral areas that seem to have had the poorest outcomes for the indicators we were able to look at. And just the final mention, dental registrations in children under 18 actually is poor in 6 out of the 10 district electoral areas. So I'm afraid that's the picture at the lowest granularity we were able to look at. Thank you.
Thank you very much, Erica, for that very clear summary of what was a lot of data to get through. And technology always lets us down somewhere. I would now like to introduce Dr. Graham Alabaster. Dr. Alabaster is head of the Geneva office of the Executive Director of the United Nations Human Settlements Programme, and he is going to look at the impact of the pandemic on people and learning for future pandemics and emergency preparedness. Dr. Alabaster is currently the co-chair of the RBM End Malaria Now multi-sectoral working group and is a Lancet Commissioner for the build-out of the death-borne diseases in cities. He has produced a variety of publications, including global reports, and has over 35 years' experience in the urban sector and has worked in over 50 countries in all regions of the world. So look forward to hearing your talk.
Thank you very much. Absolutely agree with you. Can you see my presentation?
Yes.
Yeah, okay. I'm going to just talk a little bit about the experiences of UN Habitat over the pandemic period in some other countries around the world, and to give you an example of what was going on. I'm just trying to share my. Yeah, I can't seem to change. Oh, there we go. So I just want to talk a little bit first off about the definition of urban, and of course many of the countries around the world where we work in, the idea of urban varies very much depending on where you are in the world, which continent. But the important thing is that many of the health interventions that we design, and in fact the outcomes of COVID, changed and varied very much based on the type of urban character. I think one very important factor is that, you know, we always think that the poorer countries in the world are the ones that have the slum communities and the low income and vulnerable communities. But of course, this, in fact, is even true in even some of the most wealthy countries in the world. If you look at some of the wealthy Arab countries, for example, they have migrant worker populations, which are similar, if you like, the equivalent of the low income communities in European cities and the slum communities that we see in other parts of the world. But of course, you know, COVID has been a real sort of shock to us all. But of course, we're having to deal with that now in a variety of countries and cities, along with the climate challenge and, of course, sadly, with the conflict that's now going on in many regions of the world. So, of course, these things are all exacerbating the health situation. And particularly when you come to look at the urban form and function, climate in particular is having a huge impact on health outcomes. So many things are changing as we look around the world. My organization, of course, works on urbanization and what that means. But of course, the relationship between rural and urban areas where a lot of food production takes place and where also a lot of the waste from our cities is disposed. We heard from the previous presenter about the impact on the production of solid waste the COVID pandemic had. But, you know, we really have to understand much more. One Health is becoming very popular now. As these urban areas start to grow, and this is the case in many places around the world, the relationship between the urban centre and the rural hinterland becomes increasingly important, not just because of zoonotic diseases and other things, but including access to green spaces and, of course, you know, other issues. Extreme climate events. I mean, I remember sort of even 10 years ago when we always used to say at Habitat that urbanization was a much more important issue than climate change. It was only 10 years ago because climate change was going to be another 50 years away. But here we are, who would have imagined in these past literally 4 or 5 years that we're seeing the climate change manifesting itself in the way we live in cities. Broadly looking at the situation around the world and how urbanization is going ahead, of course, it varies very much in depending on where you go. In Europe, we're already sort of highly urbanized, but in many parts of the world, there is still a long way to go. It's expected by the time we reach 2050 that nearly 3/4 of the world's population will live in an agglomeration of some kind. We're all familiar with megacities, but it's where in many countries, in many regions of the world, it's the secondary cities are the ones where there's going to be this explosive urban growth, where inefficient urbanization and access to services will mean that there are increased issues relating to urban health because of lack of access to basic services, not just health services, but many basic services that we take for granted in many of our European cities. But what's also a very important statistic, which isn't on this graph, is that of all the urban space that will exist in 2050, 60% of it still has to be built. And the reason why this is such an important statistic is the way we design our future urban space we can have a huge impact on health and other outcomes. So really, rather than seeing it as a challenge, we should see the fact that this opportunity of the urban space yet to be built needs to be considered alongside interventions in existing urban space to manage disease and improve health outcomes. So I think, as was mentioned before by Professor Sir Michael, the COVID, we learned a huge amount from the COVID pandemic. And of course, it did act like an X-ray in that it showed up many of the existing inequities and divisions in society that we see. But there were some quite interesting outcomes. For example, the issue of overcrowding was more important than density. Overcrowding, we don't just mean population densities, we mean overcrowding and access to services. We saw as well, we looked at the more developed regions of the world and less developed regions, that the comorbidities to COVID were very important. So in the global south, there was much more communicable diseases, people who were suffering from malaria, dengue, and these sort of types of diseases, as compared to the non-communicable diseases and the lifestyle diseases in Europe. There was also huge differences in the treatment-seeking behaviour. And of course, the demographics in countries. In Europe, we tend to be a sort of aging population, but many countries in Africa, a large proportion of the population are young adults. And of course, the impact that has on their ability to manage and live with disease is very important. We also found that there was a huge difference in responses of the ability of cities to respond to national sort of the implementation of national policy from governments. And the countries by and large that were very successful are the ones before the vaccines came along who understood the importance of classical public health, triaging and isolating the vulnerable. And as I mentioned earlier, you know, the migrant communities in the global north were of course also the most vulnerable section of population. But perhaps most excitingly around the world, we saw that this nimble performance of city governments in engaging, in learning and in gathering data on the COVID pandemic was very important. And of course, the overall issue was, of course, the availability of properly spatially disaggregated local level data, which we saw from the previous case study, is really, really important and helps us to make such decisions. Here in Habitat, we developed this COVID tracker, which was a very interesting system which tracks COVID at city level across the world. And there was a very good opportunity to look at how cities within the same country and between different countries in the regions compared and fared during the COVID pandemic. And this was regularly updated by us. We had feedback from lots of city managers that this was very, very useful, particularly for some of the cities which are transport corridors. And it gave us a better understanding of how some of the transmission, the epidemiology of COVID worked out beforehand. This is something that is actually relatively easy to set up as a dashboard, assuming, of course, you have the data available from local sources. We did, as a result of the pandemic, produce a report back in 2021, which goes into a lot more of the detail about what we need to learn from the pandemic, both in terms of managing the existing urban space, but also looking forward to cities, how they can be developed to encourage more healthy, productive lives. I won't go into the details here, but if any of you are interested, I can point you towards where to get a copy of this. But there were 4 basic outcomes here. Firstly, that this need to look at physical infrastructure and to understand the functioning of a city, and this you've all heard about the 15-minute city and access to services, but understanding how that works and how that impacts on disease. The second issue, and this of course was an outcome of the pandemic, was that many cities faced severe economic hardship as a result of the pandemic. And it's meant that there's a new normal in many cities now as a result of the COVID pandemic. There were changes in the revenue generation from cities and how they covered the cost of services. There's something in this report a little about that, with making some recommendations. But of course, as one would expect, one of the overall issues was how to understand better the sort of systemic poverty that exists, the inequities that exist in cities, and how really, as an indicator, if you can minimize those inequities as much, you stand a much better chance of managing during a pandemic of any sort. And then also there's some recommendations in there about sort of urban legislation and governance arrangements. One important aspect of that, which I will bring out, is in many countries, the opportunity to use civil society and the community, particularly to monitor the situations with regard to, in this case, COVID-19, but in case of any disease, and how local authorities can make use of this, if you like, citizen data to make decisions very quickly and to get data very quickly. So very important that legislation and governance, many cities have the opportunity to set bylaws. They can do so in order to encourage greater involvement of their communities and citizens. Just some additional thoughts of some areas we were involved in, not men, they would come out as apparent important things, but we did quite a lot of work on the design of some public spaces and how in COVID, for example, during the COVID pandemic, how in many countries the need to understand the transmission dynamics, design things like market spaces and shopping areas were incredibly important. We also did a lot of education and training on managing the outbreaks, but also some more in-depth assessments of particular groups of society. And in the case of Afghanistan, we looked at the female vulnerability, increased vulnerability during the COVID crisis. There are more generally, aside from the publication on the pandemic, there are some other Habitat publications which look more closely into the aspects of health and urban planning and understanding the important points. There's also some work that we did on crowding and its consequences in informal settlements, which you can also read. But if we learn overall from this pandemic and other pandemics and disease outbreaks, where we're going in the future, I think the most important thing was, of course, we had this amazing ability to get vaccines for COVID. But, that's fine. But without vaccines, and in the case of probably a new disease X, as WHO like to call it, classical public health interventions are still needed. And it's really at the local level where the surveillance, feedback and early warning and the understanding of local customs and local knowledge is the most important. As I mentioned earlier, we now have this opportunity to rethink our existing urban space, but also most importantly, to look at the urban space that's yet to be built. And really, for many of the diseases, and not just COVID, but also many of the non-communicable diseases, lifestyle indicators and access to health promotion, for example, are very important. Habitat's just started a relationship with the International Olympics Committee to look at how we can encourage governments to get more involved in the provision of sporting facilities to improve, many of the aspects related to non-communicable diseases. By way of sort of future threats and things that we're looking at, we recently, together with WHO, published a technical consultation on the urbanization of malaria. This is actually very interesting because many of you know there's a particular breed of Anopheles mosquito that's now decided it likes living in urban areas. So this is a future threat that we have to look at, particularly in light of climate change. Malaria, of course, we're still fighting malaria in many parts of the world, but we will see it expand. But that's also the case for Aedes transmitted diseases. It's not too long ago we had the Zika outbreak in Brazil, but dengue is now one of the threats, and there's currently part of an ongoing Lancet Commission on building out Aedes transmitted diseases in urban settings, and that's due to come out early next year. So we have to be aware of these future threats, and at Habitat we're trying to work, of course, closely with WHO to see if we can improve the situation. So my concluding comments, and again, this is really clearly illustrated by the Belfast case study and my dear colleagues at the Belfast Healthy City who understand this, but understanding this urban landscape and getting this key local level data is the most important issue. With that data, we can work out how to not only rethink our existing urban space, many good examples, particularly from the region where inner cities have been redesigned to improve health outcomes, but also this new urban space that's yet to be built. I've also mentioned about the need to understand housing more closely. There was in some of the work we were doing for the Lancet Commission, it was recently pointed out that the vectors for dengue in a developed world mainly breed inside the houses, whereas in the developing world, they breed outside the houses. So understanding this critical relationship between housing and the infrastructure, in this case, water, sanitation, and garbage management, is very important. It goes without saying that multi-sectoral approaches to health are, of course, most important, and we need to engage with the city leaders to ensure that we tackle both communicable and non-communicable diseases. And my final sort of point is there's still this untapped opportunity in many cities to work more closely with civil society groups, both in terms of monitoring disease outbreaks and potentially averting pandemics, but also in the responses that we do and encouraging people to adopt more healthy lifestyles. So I'll stop there, but thank you very much for your attention.
Thank you very much, Dr. Alabaster. That was a fascinating talk and a lot of learning there for everybody. So I'm now going to introduce our final speaker, Maud Laherne, who is Director of the French Healthy Cities Network. And Maud is going to talk to us about the impacts of COVID-19 crisis in French healthy cities, and again about experience and lessons learned.
Hello. Everyone, do you hear me? Okay. So I'm going to present today the lessons learned from the French Healthy Cities Network on the pandemics, because we made during the pandemics a study among our cities in France. So we are a network of around 100 cities and urban conglomerations in France. And so our cities kindly answered a questionnaire that helped us to moderate discussion groups between our cities in order to share practices, experiences, and to also gather some data on how they face some challenges and what are the strengths of the cities during the pandemics, in order for us to build on what we've learned for the next steps after the pandemics. So we gathered this data on the basis of this national study that I already talked about. During the fall 2020 already, we finalized this study. Then we moderated these exchanges of practice sessions between November 2020 and April 2021. And then at the end of 2021, we had the chance to organize our Healthy Cities conference on site in Rennes. So we gathered healthy cities in the city of Rennes in order to share experiences and learning from our experiences. And then after that, on the topic of mental health, because we didn't had the opportunity to work so much on mental health in times of pandemics, we decided to continue working group on that topic. So our experiences in France were that to analyze how do we face the change when the pandemics arise. So we had to adapt. So how the cities adapted, and what are the lessons we learned for our governance and the work we did after. So the first reactions of the French cities in March 2020 were that they had an immediate role on managing the pandemics. First, to support the coordination or to coordinate themselves, all the actors around answering the needs of the vulnerable groups, people living in the streets, for example, or people living in isolation in their home and in their flats. Their first objective was also to transfer the information they had to the inhabitants, because they were contacted by the inhabitants to know how to organize and what to do. Issue in France facing that is that many cities actually had the information at the same time as the population. The state didn't inform well in advance cities in order so that they can maybe adapt the information to the inhabitants. So they just received the information at the same time as everyone, and they needed to adapt very quickly for the actions and for the way they inform the population. Then they also had in cities to manage all the protection material, so the masks, and also for the inhabitants, but also for the professionals, because the doctors, they were not supported widely by the health authorities. So the cities actually helped for that as well. Also providing, for example, specific cars for the nurses to travel, or some rooms in where they could provide care and cure. And then one of the main role of the cities was to maintain the social linkages for those who needed daily support. So because many associations and charities couldn't continue to work during the pandemic, so actually the city agents, the social agents, they continue to provide a minimal care and support for people at home, helping to provide the food, the day-to-day products, providing medicines at home if people couldn't go out of their flat. So all this were the immediate response of the cities. But the issue is that at the state level, as a reminder, in France, health policy is mainly the competence of the state. They focus really on the immediate crisis management. So there were no room anymore for health promotion and action on the health determinants. Information was limited to no contact between each other, isolation, so something really strict in the way, in the immediate management of the crisis. And all the impact of mental health was not really anticipated and was really set aside on the first year and a half. On the other side, the positive message is that there were a lot of strengths from the cities that helped to be really flexible in the way they could adapt to the crisis, but also many inequalities between the cities in the way they could handle this. And what we learned is that the ones who actually had a local health plan, had profiles on health, and who knew really well the actors and the stakeholders and the population health, they could really be more efficient in the way they could target the specific groups more in need, the areas where they needed to target more specifically some actions, and they could also more easily articulate and coordinate between different partners on the territory, because they knew each other, because they already worked on health projects before. So all what we can build, well, that's one of the main message we had actually, is that all the local health plan we can build, all the projects we can build with stakeholders on health of the population, the data we can gather is really helpful when a crisis arrives, because we can react much more easily and effectively at local level. So the strength of the cities is that they know really well the stakeholders from their territory, so that they can contact easily each other and act. They know how to work together. They know their strengths and complementarities. So you don't have the whole thing about what is my role, what is your role. They know what is their role, and so they can really act directly. They also know how to reach the population from their territory, because it will not be the same way you reach the population in a very big city and in a very small village. So the different means in which you can reach the population, it's known by the cities. They also manage, if they had, they managed to deliver dedicated tools that they had usually beforehand, or that they improved during the pandemics, to get informed on the situation of the vulnerable people on their territory through different associations, through families, it really depends on the type of city and the way they work. Some cities also had already prepared a form of crisis management mode without having anticipated the pandemics, of course, but this was also a way of how do they work. It helped them working between the different services in the city, in the municipality, and it worked to coordinate inside the municipality the different services. Also, the city's strengths were where they had some health professionals inside the municipality working for them. And so these internal skills were really quickly mobilized during the crisis. So even internal public health doctors, nurses, but also environment and health professionals were really useful skills and competencies that could be really levelers for action in the cities. And finally, all the work that was done beforehand on mental health. So for example, we had local mental health coordination groups in cities. This could really help in monitoring all the crises of mental health that we faced in the different cities and help the different actors also coordinate between each other. So that's to really mention and to valorize what all that can be done in proximity level that the state cannot do, but that cities really have levels to act on when facing a pandemics. The problem in France is that as health is not a municipality competence as such, they lost a lot of time thinking about, but are we really legitimate to act on this? How do we act really as a coordinator of the different health organizations on our territory? What do we need to prioritize? How do we finance these actions? Because we don't have a dedicated budget for that. How do we efficiently coordinate with the other representatives from the states at local level, with the regional healthcare authority? So these questions, it really depends on person-to-person linkages. And we saw that when it's existent before the crisis, it was better. But when you have to create it, all these linkages between during the pandemics, it's much more difficult. I will go really quickly, but one of the challenges was to create, for example, the vaccination center services. So they had to create new linkages with the hospitals, for example, that may not beforehand exist. So it was one of the strengths of the pandemics, is that it forced a little bit the cooperation between cities and some health professionals and structures. But with the problematics of the responsibilities that were blurred and that may people lose time in organizing everything. But cities had a real role to play in managing the public spaces, in how making people have some spaces to meet or to organize themselves. They also had, as I said already, a real role in reaching the most vulnerables. So this was really the role of cities. A role in communication that should be different between the population and the professionals, which was not easy sometimes to do. And they also innovated a lot during the pandemics. For example, creating helplines, creating mobile teams, reaching, for example, students that were isolated in their rooms, or older people, trying also to act to keep the schools open, beside the fact that they had to manage the pandemic's crisis. So as a conclusion, and I think it's linked to all what was said beforehand, is on gathering data. And one of the situation in France is that, as said Graham Alabaster as well, is that we need local level data that in France, at least cities really have difficulties to get. We know it exists, but sharing data is a bit difficult, and you need some confidence between the actors to get access to the data and on a regular basis. So what we learned from the pandemics is that in the cities, if we could have access to local health observatories, having access to the data would have helped a lot to better know the population state of health and diversity, and answer the concept of proportionate universalism in acting and in adapting the actions to specific groups. Another issue was about how to efficiently inform the population. And in France, what was done is that we had some massive information strategies for all, but nothing was really adapted to specific groups, or really it was on the margins of the information strategy. So if we had access to local health surveillance tools, if we knew which populations we needed to reach in priority, then the strategies of information and communication could have been maybe better adapted. Also, one of the things that cities were faced with and couldn't have, well, they tried to innovate, but it was a bit difficult. It was how to mobilize the general population, also facing the mental health issues and the pandemics fatigue that was emphasized by WHO. Because what we saw is that the strategies of information to the population was more creating some kind of fear or guilt of not respecting the rules. The question is, how do we help actors to really encourage population to be more responsible facing the risk, in order for them to also have a bit of control in how they face all this. So that is more of an open question than anything. In the cities, some cities try to develop some tools for that, or some actions, but it was really not general to the French network cities. And finally, our message is also not to forget during this kind of crisis all the health determinants, because we know it impacts and we saw it in the data that was presented today, that it impacts really a lot in the way a pandemic can be handled. Quality of housing, the access to the natural environment, what is the quality and the way we interact with our social environment, how do we access quality food, how do we can continue to practice physical activity. And as a whole, is how do we better support our resource for mental health and our mental health capacities facing all these pandemics. And our message during the pandemics was to limit as much as possible closing schools or cultural places, or even trying to have some social events in order for all these people to continue to interact and feeling together, because that's one of the main challenge. And now the network is more focusing on the climate change issues, because we know that it's one of the key crises, but we should not forget all what we learned during the pandemics of the COVID-19 in order to answer better current and future crises that we will be facing. So that's all for me.
Thank you very much, Maud. That linkage and response across 100 cities is fantastic and very encouraging and really good learning, I think, for future pandemics. We're running a bit over, so I'm just going to take a few questions. So that will be from Erica, Graham and Maud. So the first question that I'm going to take is, we had a lot of data in those chapters. If you were asked to advise planners in either the health service and or public health, what are the key services you would prioritise for action?
Based on the data we have, for health services, I would say screening, because even though, for instance, bowel cancer screening increased, it still doesn't reach the target that's accepted nationally in Northern Ireland. Similarly, the targets weren't met for either breast screening or cervical screening. So screening would be one thing. I think picking up on some of Maud's points as well, mental health definitely, increase in both levels of anxiety and prescription levels. So I think, yes, there's a large mental health component that's still going on now that we need to deal with. Maternal health and early years, smoking in pregnancy, breastfeeding on discharge, those were both unfavourable outcomes. But I'd like to tie that into health and education working together, maybe more closely, especially as the early years data would be important, and then maybe trying to improve young people's outcomes at the end of their, school careers. And I just want to emphasise as well, yes, local data is really important, supporting both Maud and Graham in their pleas for it. So yes, I think education, especially early years, primary pupils and the health service areas I've indicated. But I do think social housing need and addressing that is also important. If I'm talking to planners,
Yeah.
that's the big thing. Thank you.
Thank you, Erica. There's another question here, and I'm going to ask it to both Graham and Maud. So maybe, Maud, if we start with you. Have there been any changes in the ways that services are delivered now? You did have some reflections there on the learning, but has anything actually changed across the cities in France?
Well, in France, at least the one of the I'm hearing some echo. Sorry. One of the things that the cities managed to maybe improve, or at least try to deliver better, is home visits. Knocking at the door and trying to better be in contact with inhabitants at their homes. And it's a kind of competence that was already done by charities and and also social agents in the city, but that proved to be really efficient in the way we can engage a dialogue with inhabitants. So it's and one of the challenges that was made is how to continue to work like that, how to organize some kind of methodologies of work, having an individual follow-up of people and being able to knock at the door and engage a discussion, and how to talk about health in general, not only talking about bad health, but also good health. And one of the learnings that we saw is that actually all this very first line of people that go to the house of the people is a real strength to be ambassadors for health. And actually a training was organized in France to train many people to be ambassadors of health. That can be people working as social agent, people working in different areas of I would say individual support, and that they can try to give some information about health in general, environment and health. And all this first line in France was seen as a very beneficial, at least to get the first information, and also to provide contacts with a different network of professionals, being able to support people on health.
That sounds like a very good model for others to learn from and take forward. Thank you. Graham, I suppose you've got a wider remit here. We can't tie you down to a certain country.
Well, one thing, there's two things I just wanted to mention. One, and this isn't for the European audience so much, but we found, interestingly enough, in many cities in the less developed regions of the world, that the hygiene considerations that were put in place for COVID caused waterborne diseases to completely almost disappear. So in some cases, this has given a huge lift to, some of the classical public health. People really, people in the profession, of course, have been preaching about hygiene, particularly related to water and sanitation all over the world. But this was a clear proof to them that, if they did exercise just a little bit more hygiene, then they would greatly reduce their waterborne diseases. The other thing which I think was very interesting, and this is a sort of request that we've had from many cities, is there's a lot more sharing of good practice and ideas amongst different cities. And I mean, this is where the Healthy Cities Network comes into its own. But you know, there was a very much an interest within the different regions about how these ideas work. Next, at the end of the month, I'm going to the Regional Healthy Cities Conference in the Arab states in Doha, and they're very keen to learn from the other regions and other cities exactly what they can do. So I think this is a good thing, this sharing of exchange between the cities. I mean, Healthy Cities Network has been doing that for many years, but the more we can do that, the better.
Yep, thank you. Just shows for really no expense what the outcomes, how they can be improved by, you know, sanitation, hygiene. Yeah, at very little cost. Thank you very much, the panel, and sorry we were a bit pushed there, wasn't able to take too many questions. Joan Devlin, CEO of Belfast Healthy Cities, is now just going to do some closing remarks.
Okay, thank you very much. I think we've had 3 excellent presentations this morning, and starting off with the very local level with Erica outlining some of the changes during the COVID pandemic and some issues where we've done very well. We, you know, improved in air quality, but yet in terms of WHO standard, we still have a little way to go. There were, you know, prosperity we had some good results in terms of education and employment. And in terms of place, and as Erica mentioned this in response to her question, and I think some of our other speakers have too, you know, the role of public space, but also within place, the housing in relation to demand and new build. And one of the issues that Erica mentioned actually was the increase in road fatalities and injuries in Belfast. And actually that was a common picture across Europe. And one of the other reasons that's been given for that is the speed of traffic, because there were so few cars on the road. But we moved then to Graham for the broader picture, and very much that focus on climate and on One Health, which is relatively new now in Northern Ireland and Belfast. And I suppose the 3 components of One Health are environment health, animal health and human health. And we've seen that as a result, a focus on that as a result of the pandemic. And again, I found the tracker map really interesting. But as Erica said and others, the emphasis on local level. We then moved to Maud, and we are very grateful to Maud, because Maud's actually on holidays, but she took time out this morning to be with us. But again, you know, the role of local information, the role of city governments in terms of, and that relationship between health and city governments, and that emphasis on flexibility and partnership working. So reinforced again the local level data. And so my sincere thanks to all of the speakers, to the Chief Medical Officer, who again in his opening address emphasised the contribution that by being a member of the WHO European Healthy Cities Network, the value that contribution has brought to Belfast and beyond. You know, we have many new concepts here, and we're able to share and learn from our European colleagues and our global colleagues, as Graham has emphasised this morning. So sincere thanks to all our speakers, to the Chief Medical Officer, to Karen, who has chaired this morning and who had a forensic view over the profile chapter. So sincere thanks to Karen for that. And again, finally, to Caroline and Dan, Caroline, who manages all of these events for us with such efficiency. So sincere thanks. Our next big event, the chapters are all on the website. The presentations will go on the website probably tomorrow. And our next big event is our 35th anniversary event, celebrating 35 years of Healthy Cities. And again, we will have both local and global speakers at that. So thanks to all for a very good morning.